Hello, and welcome to this webinar titled CBT for Substance Use During the COVID-19 Crisis, Part 1. This is brought to you by Beck Institute for Cognitive Behavior Therapy, and I'm Alan Miller. I'm the Director of CBT at Beck Institute. Cognitive behavior therapy was developed based upon the research of Dr. Aaron Beck in the 1960s at the University of Pennsylvania. In 1994, Dr. Beck and his daughter, Dr. Judith Beck, founded the Beck Institute. Since that time, it has become an international source for training, therapy, and resources in cognitive behavior therapy. The mission of the Beck Institute is to improve lives worldwide through excellence in CBT. If you don't already know, you can receive a free copy of a newsletter that is produced by Beck Institute by going to beckinstitute.org/subscribe. So my agenda for this webinar is to provide the rationale for using CBT to treat substance use disorders. In particular, I want to talk about cognitive conceptualization and the treatment planning that results from that under the blanket of the COVID-19 crisis. So we start with the current situation. And in the current situation, we know that there is increased use of substances since the beginning of the crisis. US sales for alcoholic beverages rose 55% in the week of March 21st. We don't know as much about the impact that the increased use has had across the country or across the world for that matter, but we do know from anecdotal evidence and from my own local area where I live, opioid overdoses tripled this year just by the end of March. Alcohol-related and prescription drug-related deaths intermingled with opioid deaths. Substance-related deaths are occurring at 3 times the pace they were last year at this time. And the administrations of naloxone already exceed those for the entire year of 2019. We know also that chronic conditions like COPD, cardiovascular disease, and other respiratory diseases have been found to worsen the diagnosis in respiratory illnesses like SARS and MERS. The case fatality rate for COVID-19 in China was 6.3% for those with chronic respiratory disease compared to 2.3% for those overall, according to China's CDC. We know also that in China, approximately 53% of men smoke, by contrast to just 2.4% of women. So that may help explain the higher mortality rate among men compared to women, as reported by the CDC in China. But that's a figure that we will have to continue to monitor and follow. In the United States, the most commonly used substances are first tobacco, followed by alcohol, cannabis, and opioids. We know that chronic use of those substances contribute to cardiovascular diseases. And so therefore, people who are chronic users of substances may be more likely to be vulnerable to the COVID-19 virus. In 2015, there were approximately 22 million people in the United States identified as having a diagnosed substance use disorder that warranted having specialty treatment in substance use. At the same time, only 2.3 million, or 11% of those 22 million, actually received that specialty treatment, which means that about 19.3 million, or 89% of the people, did not receive the specialty substance use treatment that had been recommended to them. So what does all of this mean about predicting how things are going to progress from here forward? Due to the immediate crisis, it's likely that the use patterns will continue and the mortality rates will continue to be high. Now, after the immediate crisis and people return to their normal schedules, most people will also return to their normal use patterns. A small percentage of people, which will still be a large number of people, will continue to use at the higher levels, and they will experience problems due to their substance use. So considering that we already don't serve most of the people who are diagnosed and recommended for specialty substance use treatment, and we add additional people to that number, the load on the treatment system is going to be overwhelming, and we'll have a crisis within the treatment system itself. So what is the efficacy of CBT for treating substance use? One meta-analysis was conducted in which 34 well-controlled treatment conditions were evaluated. 5 of those for cannabis, 9 for cocaine, 7 for opiates, and 13 for polysubstance users. The effect sizes ranged from the low moderate to the high moderate range, depending on the substance disorder and the treatment under study. So the conclusion is that the effect sizes for CBT treating substance use are comparable to those of other efficacious treatments within psychiatry. Additionally, a review of literature shows that CBT, which actually represents a number of different techniques and interventions, can be effective, and that those different interventions and techniques can be combined for particular individuals to bring about better results. Overall, the indications is that those interventions have demonstrated efficacy, and in addition to that, they can be used alongside pharmacotherapy to bring about the better treatment results in the long run. Harm reduction is a treatment that has received more attention in recent years, mostly because of the opioid crisis. And peer-reviewed studies of that support the effectiveness of harm reduction, and that without any indications of iatrogenic effects. So the indications are that this provides additional tools to us, especially for those individuals who may not be ready, willing, or able to pursue full abstinence as a goal in treatment. A nice blog was written for us by our colleague, Dr. Corey Newman, a couple of years ago, and that link to the blog is here. And what it does is point out the compatibility of using CBT, whether the goals for treatment are abstinence, harm reduction, medication assistance treatment. So that might be worth taking a look at. There are some considerations for treatment on a broader level that rise above and beyond just a single kind of treatment like CBT. So these are things that we take into consideration and use alongside the treatment model of CBT. One of those is stages of change. So we know that many people who are diagnosed and recommended for treatment are not actually at a stage of change where they are ready to enter treatment. So some people are in a pre-contemplative stage, other people are in an action stage, and some people are just about ready to terminate treatment and need a relapse prevention plan. So we pick those CBT techniques that are most applicable to the individual that we're working with and the stage of change that they're in. Additionally, the level of care is something that needs to be considered, that depending upon the seriousness and the impact that it has on a person's level of functioning and their quality of life, they may go to or be appropriate for different levels of care. CBT is used and has been used effectively in all different levels of treatment. This may be self-evident, but developing a healthy lifestyle, including eating patterns, exercise, and routine sleep schedule, are things that will help to bring about and stabilize a person in the recovery process, as well as helping them to sustain their recovery once they do reach stabilization in the recovery process. So there are three kind of broad goals in terms of treatment specifically to the use of substances, and that would be abstinence, medication-assisted treatment, and harm reduction, which CBT is used compatibly with all of those goals. We need to remember also that there are comorbidities with substance use, and especially now with the COVID-19 virus, that we're going to have more people who are going to come out of this with a new diagnosis of post-traumatic stress disorder, depression, suicidality, anxiety, insomnia. And people with serious and persistent mental illness are going to have exacerbated conditions, and they're going to increasingly use substances to cope with those new symptoms and conditions. So in addition to just increased use of substances, we're going to have more people with more mental diagnoses, and we are going to have a greater insurgence of people who have dual diagnoses, again, which are likely going to overwhelm our system. Some of the common challenges in working in people who are trying to recover there's a long list here, that most of these things are true on any given day for people. These are challenges that they face when they're trying to recover. But the COVID-19 crisis provides even more challenges, and add things like fear of infection and fear of withdrawal because not being able to get out and have access to the substances that people are most used to. Impulsivity, insomnia, depression, anxiety are all increased at this time. And so the stressors that a person has in their life have been increased, and that's going to multiply the problems that they have, and we already know increases their level of substance use and gives us more to work on as we go forward. Some of the common treatment objectives that we expect that people are going to be looking at are very similar to those in the past, that people are going to want physical relief from urges, cravings, things like that. They're going to want help making decisions about how to proceed, and that may involve eliciting and articulating their values and aspirations, forming a vision for the kind of life that they have that they have for themselves in the future, and becoming more active and putting in place a step-by-step plan to help them to achieve that vision that they have for their lives. And these are the many different kinds of CBT interventions and techniques that exist that help people to move in that direction and achieve those goals and the vision that they have. And our goal is through conceptualization and treatment planning to identify those techniques that will be most helpful to the individual that we're working with right now, given the challenges that they have in their lives. So let's get to the cognitive model. And just a reminder, the cognitive model tells us that it is not the situation itself that causes distress in our lives, but rather it is our interpretations, that is our thoughts and our beliefs that about those situations that brings about the distress that we experience. Within the CBT model, there are some things that we value greatly. So these are things that we think and want to be in place even before we try to utilize and apply the techniques that we would use to develop coping strategies and develop skills. So the therapeutic relationship in which the therapist is able to express empathy and reflect that to them so that the person feels that they're really cared for. The acceptance, unconditional acceptance of the individual regardless of where they've been and regardless of what their goals for treatment are at this point. And we collaborate with people to help them to figure out what it is they want to do, how they want their lives to be, and we help collaboratively decide which interventions will be used and will be most useful to them to help them realize their direction toward recovery. Values and aspirations of the individual are very important. We have the person use those as the things that generate the internal motivation and keep the focus and the vision on the path forward toward recovery. Empirical evidence collecting evidence through behavioral experiments and role plays and different kinds of activities. We want to use that to collect evidence as a means to allow a person to evaluate their thoughts and beliefs and use it as corrective information. We also believe in the importance of structuring our sessions such that things like setting the agenda, using evidence-based techniques, and developing action plans or homework assignments for our clients will help to keep things focused and ultimately will bring about better results from the treatment, and the treatment techniques will be more effective when we keep that kind of structure around them. One of the things regarding therapeutic relationship that isn't often discussed, or Aristotle isn't often discussed in connection with the therapeutic relationship, but in his Rhetoric, he talked about different kinds of things that are important when working with people. And those things, logos refers to the kind of information that we have, the research results that we have, that we can say to people that here is what we have, and we know that these things can help. So that's important. The pathos is the emotional connection, the unconditional acceptance. That also is very important, obviously. The ethos is the third thing. And interestingly, Aristotle thought that this was the most important thing. And the ethos refers to the credibility that we have as human beings, our genuineness, and the degree to which what we say and what we do is able to earn the trust of the client that we're working with. And that trustworthiness, because of our credibility, is the thing that is most important in developing the relationships. Aspirations I've referred to a couple of times because these are the things that provide the vision for what kind of life our clients want to have. It's based upon values, and when we identify what is important value-wise to our clients, whether it be family or work or other kinds of activities, then we elicit aspirations. What would your life be like if you were living and realizing your aspirations in regards to those values? We have them imagine that and feel the positive emotions that they will experience as they're realizing their aspirations coming to fruition. And we set up a paced plan, step by step, that the client will follow in order to get to that realization of their aspiration. So cognitive conceptualization is something that is really important within CBT. And the CBT model for substance use takes into consideration many things. Some of the things that are important that will affect a person's decisions to use substances are things that may have been developed even before the person had substances or knew what substances were there in their lives, like things like genetics and personality traits, early life experiences. But then we take those and add those to external stressors in their life, their social network, what kind of experimentation they might have done with substances. All of those things added together contribute to a person developing their beliefs about themselves, about other people, about the future, and indeed about substances themselves. And so we take all of those things and put into context then the immediate stressors in a person's life and what they believe the role of substances is in dealing with those stressors, then that will lead to, in some cases, a decision to use. And the result of the decision to use will produce more thoughts, emotions, and behaviors. So the model then is that we think about what does a person believe about substances, and if they believe that substances are safe, helpful, and fun, and when they're experiencing stressors like worrying about becoming infected, concerns about withdrawal, losing relationships, hopelessness, with the backdrop that they believe that substances provide relief and comfort, then that is going to be likely to lead to a decision to use. And the result is, that's a good idea, I feel great, I'm going to continue to use. So how do we take that model, conceptualization, and use it for treatment? So we think about a situation where a person needs to resolve a situation. So in the current environment, urges and cravings to use are quite prominent, obviously. And if you follow the arrow over to the side, you can see that we can use CBT techniques such as relaxation, mindfulness, distraction, exercise, or medication. All of those things can be used for dealing with urges and cravings right at the outset. However, if a person didn't have those and they still have the automatic thoughts, I can't stand this, I need to do something to relieve the urges and the cravings, then if you go over to the other side of the slide, you can see that using Socratic questioning and doing behavioral experimenting, we can get evidence to evaluate those beliefs and look for developing alternative beliefs that we might use in the future to do it. Going back to the other side now, the stressors that come up, being isolated, bored, feeling stressed. Well, for those things, a person can call or write family or friends, attend a virtual 12-step meeting. We can do role plays with them in session to prepare them for how to deal with those situations. And then back to the other side, the beliefs about the substances themselves. We can provide psychoeducation. We can engage in Socratic questioning. How long do you get relief? Is it the only way that you've ever gotten relief? And we use coping cards as a way to put down coping strategies or reminders of things to do, or even to reward oneself, reinforce oneself for the things that they might have done. So now we have all kinds of new skills, coping strategies to put into place to use that all go toward the decision. And when it comes to the final decision, we can use things like a cost-benefit analysis. We can still delay a decision. We can provide distraction and explore alternatives. So we have multiple ways of using CBT techniques to deal with each step that leads up to the use. So if indeed a person did that, starting off with the urge and the craving, instead of the I can't stand it way of thinking, they can realize, look, I've been through this before and I have more tools now. So what we do is catch it coming right out of the starting gate, that they can think differently about their ability to deal with it. When we go to this side with the stressors of being isolated and bored, they can call, write family members, they can attend meetings, they can do stretching, they can do other kinds of things. And when we go back to the other side, to the beliefs about the substances, well, in fact, they give relief, but it's really only temporary relief. And at the end, I still have all of my problems. So when the alternative beliefs and the additional coping strategies and new skill development come together, it will make it more likely that a person will come to a decision not to use. And then the result of that is, the immediate thought is, that I've done a good job. I've held it off, I've dealt with it. So I'm relieved, and I feel a sense of relief and emotion, and my immediate behavior is, I can just be still and enjoy this for the moment. And perhaps even more importantly, the second stage of this is that the people begin to reevaluate their beliefs about themselves and other people. So they start thinking about themselves as being a good person, and they start feeling proud of themselves for dealing with the urges and the cravings. And then they develop a sense of self-efficacy because they know that they can use the tools that they have in order to not use. And so their continued use, the more they benefit and do the things they want to do for recovery, the more likely it is that they will continue to do them. All of this adds up to a path of recovery. So what do we call recovery? Recovery is returning a person to their highest possible level of functioning with the least amount of external support. Doesn't mean no external support. Obviously, we need other people. Some of us need medications, any variety of things. We need other things. We want them to get the right amount, not too much, not too little, so that they can reach their most successful point and highest level of functioning. So how do people progress or what is an episode of care in CBT like. In the beginning, we do an assessment just like anybody would. And before we get to the techniques, we start building the therapeutic alliance. We start identifying goals through the values that a person has. We provide psychoeducation, and we socialize them to the model. And so in the early sessions, we collect information to develop the cognitive conceptualization. We identify their values, and we elicit their aspirations about those values to establish a vision for the future, for the kind of life that they want to have. We use those aspirations and the positive emotions associated with them for internal motivation throughout the episode of care. We anticipate challenges, because if this were easy, people wouldn't need to come to us. So for each challenge that a person has along the way, we identify coping strategies, develop skills, new ways of thinking about things so that they have a way to deal with those challenges as they emerge. And we deal with the immediate problems that they have in their lives first. As we go into the mid-phase, we continue all of the previous activities, but we begin to focus on a transition to making behavioral changes. We use collaborative empiricism. We work together, design experiments to acquire evidence to support or that does or doesn't support the beliefs that they hold, and use that as corrective information to develop alternative thoughts and beliefs. We continue to use values and aspirations for motivation, and we monitor progress all through the course of therapy. We revise and add treatment goals as indicated all through the treatment process. And in the end phase, we continue all the above activities, but we prepare a person for discharge from formal treatment. We do that, we develop a relapse prevention plan using largely a functional analysis, which links together all of the different challenges that we anticipate that a person will experience as they go out and experience life. And we develop coping strategies, different ways of thinking, and new skills to have them prepared to deal with each one of those challenges as they occur after a person completes formal treatment. So what we've talked about during this webinar has been a review of the current situation and the impact that that has on the use. We've talked about the efficacy of CBT, treatment considerations, the cognitive model, including case conceptualization and application of those techniques and identification of the techniques and interventions that we use, and then how all of those things are put together to identify and explain an episode of care with CBT. Some additional resources that you might be interested in. First, the book originally written by Dr. Beck in 1993, Cognitive Therapy for Substance Abuse. And then additionally, there are some links to sites on the Beck Institute website, some for just the general website so you can explore on your own, but there are also specific links to resources for COVID-19, specific link about training and supervision resources that are available through Beck Institute, and also a link to the certification page in case you might be interested in that. So it is my hope that you've seen or heard something here that will be helpful to you in your continued work with clients who experience problems as a result of substance use. And in part 2 of this, we'll talk about how to elicit and use the aspirations and how to conduct and apply various kinds of CBT techniques to help a person during the recovery process to achieve their goals. So I'll look forward to seeing you then. Thanks.